HCM stands for hypertrophic cardiomyopathy. We know that the left ventricle hypertrophy occurs when there is pressure overload or volume overload. Pressure overload occurs when the patient has aortic valve disease or systemic hypertension, and volume overload can occur with aortic valve disease, regurgitation preferably. But hypertrophy that occurs in the absence of these factors like systemic hypertension, aortic valve disease, and infiltrative disorders and storage disorder is called as hypertrophic cardiomyopathy. The other names for this disease are hypertrophic obstructive cardiomyopathy (HOCM), asymmetrical septal hypertrophy, or idiopathic hypertrophic subaortic stenosis. Now commonly called as hypertrophic cardiomyopathy because most of the patients may not be having the obstruction. So this disease is better termed as hypertrophic cardiomyopathy with or without obstruction. Incidence, it is a common incidence with an incidence of 1:500 in Asia and other regions also. It is one of the common cause for sudden death in young patients. It is autosomally dominant inherited. Though many mutations have been identified, the most common one are the MHC7 and MYBPC3, which is found in nearly 80% of the patients. Nearly 1400 mutations have been identified so far, but these are the most common one. Though the phenotypes, that is the cardiac hypertrophy seen in the infants and neonates also, the disease manifests in the later part of the life, and there is disarray of the enlarged myofibrils and myocytes, which causes the myocardium to undergo ischemia, and this ischemic scars represents the substrate for future ventricular arrhythmia generation. There is non-uniform ventricular thickening. The common region affected are the interventricular septum, though the patient can also have concentric hypertrophy, midventricular hypertrophy, and this is special form of HCM called as apical HCM. LVOT, that is left ventricular outflow tract obstruction, is present at test in 30% of the patients, that is 1/3 of the patients, and 1/3 of the patients develop this LVOT obstruction during exertion. A classical feature of this HCM is the systolic anterior motion of the anterior mitral leaflet, which pulls the anterior mitral leaflet into the left ventricular outflow tract. This movement, along with the hypertrophied septum at the outflow tract, causes the obstruction. So, in order to overcome the obstruction, the ventricle has to generate more power, which leads to hypertrophy later. And this anterior motion of the anterior mitral leaflet causes a mitral regurgitation that is posteriorly directed. Clinical features: these obstructions are typically aggravated by inotrosis because it increases the force of contraction, bringing the anterior mitral leaflet and the septum closer, thereby aggravating the LVOT obstruction. And dehydration. The murmur is heard, systolic murmur, which is harsh and late peaking, and typically this murmur is increased by standing and Valsalva maneuver. The common symptoms are exertional syncope, dyspnea, and angina. Diagnosis can be diagnosed by 2D echo. Biopsy may be needed if we suspect some infiltrative or storage disorders. Treatment: we have to limit the heart rate, that is the mainstay of treatment. Heart rate can be limited by beta blockers and calcium channel blockers, that too rate limiting calcium channel blockers like verapamil and diltiazem. As the heart rate is slowed down, the period of ventricular diastole increases, thereby increases the ventricular filling. This filling will overcome the obstruction. Disopyramide is a negative inotropic drug that can also be used. The other options are surgical myectomy and alcohol septal ablation, but both these procedures carries the risk of complete heart block. Mitral valve repair is not necessary because once the obstruction is relieved by some procedures or drugs, the mitral valve regurgitation automatically corrects itself. Kindly, these patients should be asked not to involve in vigorous physical activity and competitive sports, which increases the heart rate. An implantable cardioverter defibrillator (ICD) can be added for patients who have added risk factors, and HCM patients are at risk of developing atrial fibrillation because AF is the most common arrhythmia in HCM. Note that digoxin has to be avoided because digoxin is a positive inotropic drug which will aggravate the LVOT obstruction. If you want to convert the atrial fibrillation to sinus rhythm, two drugs can be tried. One is amiodarone. Another one is disopyramide, which is a negative inotropic drug. And anticoagulation can be considered to prevent embolic manifestation if the patient has atrial fibrillation. We saw that ICD is needed for patients with added risk factors. The added risk factors are patients who have a history of cardiac arrest or who had an episode of syncope which is not attributable to some other causes, and when the left ventricular thickness is more than 30 millimeter and the patient had developed either a non-sustained or sustained ventricular tachycardia, and the patient has family history of sudden cardiac death and abnormal BP response during exercise. Normally during exercise our BP increases, but these patients BP will not increase during exercise, and these are the risk factors. If these risk factors are present in a patient, we can consider ICD. This is the flowchart given in the Harrison regarding the management of HCM.